That's by Dr. Rania Mogawer from Egypt. And he'll be talking about efficacy of narrowband UVB. I'm sorry, she'll be talking about efficacy of narrowband UVB with or without oral mini-pulse steroids in stabilization of vitiligo activity in skin phototypes 3 to 5, a double-blind randomized placebo-controlled prospective multi-center study. That sounds really relevant. Over to you, Dr. Rania.
Efficacy of narrowband UVB in stabilization of vitiligo activity in dark skin phototypes. On behalf of the Egyptian Vitiligo Group. Vitiligo management essentially entails two main goals, repigmentation and stabilization. Phototherapy has been the management pillar for vitiligo. With narrowband UVB, achieving both the repigmentation through the stimulation of the melanocyte reservoir together with an immunomodulatory effect suggesting a strong stabilization of vitiligo. So what's in the literature regarding the stabilizing effect of narrowband UVB in vitiligo? Immunomodulatory effect of narrowband UVB has been well established and it acts in a number of ways. However, the studies showing the stabilizing effect of narrowband UVB in vitiligo are scanty, and no randomized controlled trials comparing narrowband UVB to steroids as regard its stabilizing effect. In spite of having daily stabilizing tools, they all require combination with narrowband UVB to optimize their effect. In addition, stabilizing effect of narrowband UVB in dark skin phototypes has been questioned due to the higher activity of the melanocytes and possible interference with the penetration of the UVB into the skin. So our aim of this study was to assess the efficacy of narrowband UVB in stabilization of vitiligo activity in darker skin phototypes. This was a multi-center study conducted in 5 university hospitals all over Egypt. Patients were randomized to one of two groups, narrowband UVB with a placebo or narrowband UVB with mini oral pills. Patients were assessed and followed up at the baseline and every 2 weeks for a total of 6 months. Standardized photographs were taken at each visit, and patients were assessed clinically at each visit for any new lesions as well as expansion of old lesions, together with comparison with old photographs. Activity status was assessed based on the development of new lesions, new cover, expansion of old lesions, together with clinical signs of activity as trichroma, confetti-like lesions, ill-defined edges, and depigmentation of a repigmenting lesion. Cessation of activity was defined as lack of any sign or symptom of activity, while failure of cessation of activity was defined as the patient having one or more sign or symptom of activity. For patients with fluctuating activity, longest duration of ceased activity was calculated, and relapse was defined as relapse by the end of the longest duration of ceased activity. We recruited 100 patients, 80 met eligibility criteria. They were all skin phototype 3, 4, and 5. 40 were assigned to the narrowband steroid group, and 40 were assigned to the narrowband placebo group. 34 patients completed the study in the narrowband steroid group, while 30 patients completed in the narrowband placebo group. On comparing both groups, there were no significant differences regarding cessation of activity, where at the end of the study, 22 patients in the narrowband placebo group achieved cessation of activity compared to 28 patients in the narrowband steroid group with no significant difference. Similarly, no difference was reported regarding the onset of cessation of activity, the longest duration of ceased activity, as well as the incidence of relapse. On fortnightly assessments, regarding the signs and symptoms of activity, there were some differences picked up between both groups, as well as in the activity score, which is given based on the total number of the signs and symptoms of activity that the patient was having at each point in the follow-up in the study. So the fortnightly assessments have shown earlier control in the narrowband steroid group regarding the development of new lesions, confetti-like lesions, trichroma, as well as cessation of activity. Both were equal regarding the cobbler, expansion of old lesions, depigmentation of repigmenting lesion, as well as West and Vitus scores. All differences disappeared by week 22, apart from ill-defined edge, which persisted in 7 patients in the narrowband placebo group compared to none in the steroid group. So our conclusion that narrowband UVB can achieve both treatment goals, the stabilization and the repigmentation, even in dark skin phototypes. It can be used as a safe monotherapeutic tool. However, the added value systemic steroids cannot be undermined to hasten the response and improve the patient's compliance.
So thank you for that very relevant presentation, Dr. Rania, because I think we do need, all these tools for treating vitiligo, whether it is phototherapy and adjuvants. What I'd like to ask you, you've done this paper, what in your opinion, where do you think the oral, mini-pulse steroids come in? Do you really think they're useful overall for vitiligo, with or without phototherapy? If yes, why? If no, why do you think so?
Yeah, definitely the oral mini-pulse steroids is important in the stabilization, and it has added value when combined to the narrowband UVB. But the point that in some situations we're faced with some patients that we cannot give the steroids either for one or more contraindications. So here we can give the narrowband, achieving both the repigmentation and the stabilization, but definitely we cannot underestimate the value of the mini-pulse steroids in the stabilization of vitiligo.
So in other words, you feel that oral mini-pulse is still a good, it's an old treatment, but you still feel that it has its value, especially in resource-poor setups, and it has its own place.
Yeah, definitely it has its own place. But in the stabilization rather than the repigmentation, but the narrowband can achieve both goals.
Yeah, that's what your study showed. So I think it's been a wonderful talk, Congratulations. Do keep up with your work.
Thank you.
And yeah, so I'll now go over to the next speaker, and we can come back if there are any questions. There is a question, so I'm going to take that up quickly. This is from Dr. Indermeet Kohli. Very nice study. What was the baseline vitiligo affected body surface area, and was that comparable between the two groups?
Yeah, it was comparable. There was no difference between the body surface area, the average body surface area in both groups, and the average body surface area was less than 5. It was the median was 2.5 actually. So most of our patients were body surface area less than 5%. We were recruiting active patients, and most of them were less than 5% body surface area.
Okay, so thank you so much.